This week's Friday question is about length control. What is it and what can we do about it? Before we talk about what length control is and why it's so important, we should first explain what is working length. Working length is the chosen depth of your instrumentation during your root canal therapy. Therefore, it is the depth to which your hand and rotary files will go to in order to obtain a clean and well-shaped root canal. Of course, cleaning is more of a chemical process and can happen beyond the depth of your instrumentation, but instrumentation is generally limited to the length that you call working length. Now, while this seems to be a fairly easy explanation and a concept to grasp, as Dr. Koch used to say, this idea of how deep is deep enough and what is and where should we determine the working length and instrumentation to has been the subject of many distended carotid vein arguments in endodontic history. In dental school, we learned that the working length should ideally be set at the cemento-dentinal junction. But of course, we also are told that this is a histological landmark whose exact location cannot be verified clinically. Therefore, we're left to guess that where is this, a mysterious place, and is it based on a periapical radiograph or just the electronic apex locator? And it seems to be true that those are some of the practical tools that we have in order to arrive at that conclusion at a clinical level. But let's just take a quick look at the cemento-dentinal junction. This junction creates a situation akin to placing two funnels together and thus creating a constriction referred to as the minor diameter and the major diameter. The minor diameter is the apical constriction, and according to the most popular instrumentation camps, our goal is to try to preserve this anatomical apical stop if at all possible. As I explained in last week's video on resistance form, a circle's area increases as a square of its radius, and therefore keeping the apical constriction as small as possible helps minimize overfilling of the canal with both the filling materials as well as our caustic irrigation solutions such as hypochlorite. Therefore, keeping the apical constriction helps minimize trauma to the periapex and less postoperative symptoms for your patients. So, for this tutorial's purposes, let's just assume that our goal is to keep the apical constriction intact and instrument to just to it. But how do we do that? Well, we use a combination of an apex locator and a file shot radiographs to confirm a given working length. Now, apex locators will be the subject of a future tutorial. Once set, how can we maintain this length? Well, we can do so by paying particular attention to our reference points. Let's face the facts, endodontic therapy is a very high skill and quite precise clinical procedure. Oftentimes, measurements have to be accurate to a half a millimeter, and 1 millimeter can make the difference between a painless root canal procedure or a painful one postoperatively for your patient. So, in order to set accurate working length, make sure that all of your files have high-quality stoppers that do not wobble. Wobbly stoppers are very difficult to determine what the correct working length and the reference point is. So also make sure that your reference points are solid and reproducible. If possible, make sure that you measure from a really flat plane rather than a round cusp tip or a rolling marginal ridge. That could introduce a certain amount of error of reproducibility each time you're trying to remeasure. So having flat planes will help make your working length determination as well as maintaining it a little bit more accurate. I sometimes see people that take the stopper off and use the file calibration markings as their reference point. Well, worse yet, I've even seen people that say that they eye it and use that as their reference point. The problem is that these calibrations may vary from file to file, and length can change as newer martensitic files unwind and may even get longer during your instrumentation. So make sure that you continuously check and re-verify and measure the length of your file with a very accurate ruler. And speaking of that, You and your assistant should make sure that if you have different rulers that make your measurements on, that your rulers are calibrated with each other, as measurement readings can change or vary from one ruler to another, and 20 millimeters in one ruler may not necessarily be 20 millimeters in a different ruler. Don't forget that these things are not quite measured to that high of a standard as you would expect, and for that reason you should really try to get accurate rulers, preferably metallic ones that do not change after multiple autoclaving. Failure to pay attention to these simple concepts can lead into short or long preparations and loss of original working length. A good trick for setting stable reference points was published originally by Dr. Scott Perkins several years ago, and in that article, Dr. Perkins basically alluded to a technique in which he recommended flattening the cusps for more stable reference points. And that I agree with that, because it creates a flat surface that is far easier to measure a working length and to also be able to maintain it by keep the reference relationship between a flat stopper and a flat surface of a flat cusp. And this is actually why the first burr in Reworld Endo's Access Kit is an efficient flat-headed diamond burr that flattens the cusps and provides a flat plane for a more accurate stopper to cusp relationship and a more accurate working length determination as well as maintenance. Furthermore, flattening the cusps also takes a tooth out of occlusion, which reduces the incidence of post-operative symptoms by reducing functional load during the healing phase of the tooth. Lastly, please remember that highly curved canals may end up experiencing a change of length due to straightening of the file that occurs during preparation with larger tapers. And this length change can be as much as a millimeter in some canals, depending on the curvature. So you may have to keep this in mind and also make sure that you're instrumenting with smaller tapers, which will help reduce this effect of working length change in curved canals. In conclusion, the best way to maintain good length control is to, first of all, understand the importance of working length in your treatment outcome. Then you need to set length with a high precision and thick and non-wobbly stopper, and then have also solid, reproducible reference points that are consistent, and in that sense, flattening your cusps in cases where a crown is going to be indicated will be helpful. Also, use magnification in order to see this cusp to stopper reference relationship and monitor this measurement relationship constantly throughout your instrumentation by checking and rechecking your file length and making sure that your stoppers have not moved accidentally during the multiple strokes that you are taking during your instrumentation. Also, make sure that you and your assistant rulers are calibrated and present the same lengths across the board with all the other rulers in your operative that are going to be used for working length measurements. And lastly, the foundation of proper length control is correct measurement of working length. And this will be the topic of next Friday video question. Until next video, I'm Ali Nasseh, and I hope you found this information helpful.